We have now a session on migrants and systemic resilience in health services. We have 3 speakers. We have a presentation from Steve Thomas, which will be followed by remarks from Jim Campbell and Isabella Aboderin. So, and then there will be lots of time for questions. And let me just tell you how to ask these questions. While it is great that we can use this technology to have a conference online in an entirely safe way, it doesn't allow for people to ask questions in person. So please use the chat box to pose a question. You find the chat box as a button in the bottom of your screen, and then as you click on that, you can enter your question, and you can select above the question to whom you want to send it. And please send it to Migration Policy Center so that we can actually manage the questions and make sure we see your question, because it can be quite difficult to find your question again in a lot of text. So please select Migration Policy Center as an address basically for your question. So to start the session, a little bit of just an observation of context. I found it a particular moment of this pandemic when Boris Johnson came back from the hospital and said that they had saved his life. Literally, he said it could have gone the other way. And he was explicitly thanking 2 nurses. And these were Jenny from New Zealand and Louis from Portugal. So also for those who don't read statistics that have been telling for years how important migrants are in the health systems of many countries, this really hammered the point home to everyone who was just following this on TV. So with that, we can move to the presentation by Steve Thomas. He is the Edward Kennedy Professor of Health Policy, Public Health and Primary Care at Trinity College, Dublin. He's also director of the Center for Health Policy and Management. And his presentation is entitled Strengthening Health Systems Resilience, What Role for Migrants and Migration Policies. And this presentation comes ahead of a written piece that he will supply to the MigResHub, and that will soon be available online on our MigResHub website. So Steve, the floor is yours.
Thanks so much, Friedrich. Okay, so I will now try and share my screen, and hopefully this will work. Okay, so I've been given the unenviable task of presenting in 10 minutes. I think it was Winston Churchill who once said, if you want me to speak for 45 minutes, I can do it right now. If you want me to speak for 10, I'm going to have to stop and think about it. So put a little bit of thought into this, but 10 minutes is not long. Anyway, here we go. And I'd just like to thank my co-authors, Poeschel Fleming and Catherine O'Donoghue, who hopefully are waiting in the wings should I not be able to answer any of the questions. So really this presentation is coming off the back of a policy brief that I led for the European Observatory on Strengthening Health Systems Resilience, which tried to draw together some key findings, particularly from the early COVID experience. We were ready to go with it just before COVID hit, and then we had to do some rapid rewriting when COVID, the pandemic, launched upon us, and it is still going, of course. So what I want to do then is really to think a little bit about what is health system resilience. So that's an important question, and one that is not always obvious. Strategies for building resilience, and particularly those strategies that relate to the workforce. I think that's quite an interesting focus. And then I'm going to be thinking about, you know, is the role of what is the role of migrant labour? Does it make us more resilient, or does it actually make us more vulnerable? And that probably depends on the particular way in which we do it. Which is probably where I'm going to end up for my discussion. So in terms of resilience, health system resilience, well, I first started doing some work on this whole topic about 10 years ago. We're looking at health systems resilience in relation to the economic crisis and in relation to financial austerity. And Ireland went into receivership. It was one of the pigs that basically the IMF took over. And the way I was thinking about resilience then was that this whole idea of absorption, adaptation, and transformation. So first of all, you try and absorb the shock, you protect against the resource imbalance that's coming either from a surge in demand or a shortage of supply of resources. If you can't do that, you adapt to it, you make efficiencies, you try and deal with it. If you can't do that, you try and change your system. So that's like a series of dominoes that fall over. So hopefully, if you can stop it at the absorption phase, great. But if not, then you have to work through the other phases too. That's how I used to think about resilience. I don't think about it like that anymore. I think there's a much bigger picture, which is to do with shocks and shock cycles. And actually, in this world at the moment, we are increasingly exposed to shocks, whether they are to do with climate crisis or austerity or pandemics or whatever. So I think it's better to take a much broader picture and see resilient health systems are those that are able to manage well each stage of the shock cycle. So it's not just to do with impact and management, which is the third stage, the absorption, adaptation, and transformation. It is to do with that, but it's not just to do with that. It is also about stage one, preparedness. Am I ready for particular shocks to hit me? And the preparation might be different for different shocks. Can I deal with the shock onset and quickly deal with it and identify it and see what needs to be done? Shock impact and management, and then of course, recovery and learning. How does the new normal change the health system? And what do I need to do to work with that? So I'm prepared for the next shock. So you can see there's sort of a dynamic shock cycle there. Then what we did for the European Observatory policy brief is we looked at key strategies that would build health system resilience. And we did that not just in relation to COVID, but we did it in relation to other shocks. We looked at Ebola, we looked at the financial crisis, we looked even at large-scale migration in the Middle East. And we came up with these 13 different strategies. And I'm just putting them here for completeness. I'm not going to go through all of them because there's quite a lot. I will now hone in on ones where I think it specifically and directly relates to the workforce, and also in relation to workforce implications. So really the three here, I'm thinking about sufficiency, I'm thinking about flexibility, and I'm thinking about motivation and engagement. Those are my three key areas. So sufficiency, partly that's business as usual. Do I have enough human resources to staff the services that I want to provide? Do I have enough of the right kind of staff in the right place doing the right things? And that's business as usual, but it's also in relation to surge capacity. And I think many countries now have been looking to see how they can bolster their surge capacity at this difficult time. I think there's also stuff around flexibility, the ability to be able to redeploy workforce within a healthcare system, but also the ability to innovate and learn and change the way of doing things, change the way of delivery. And we can see that in terms of telemedicine. I mean, for years, GPs in Ireland have been unsure about whether to embrace telemedicine, and they did it in 3 weeks with COVID. So there's ability to innovate. Can we do that? And then finally, of course, the issue of motivation and engagement of health professionals. And of course, as the longer COVID goes on, the longer a shock goes on, the more that's probably going to be eroded. This is one of the key challenges that we found in Ireland through austerity, is the demotivation of the workforce after a certain stage. So, and of course, that's critical. We can't take that for granted. Do we have a sufficiently well supported, resourced, remunerated, heard, connected, appreciated, protected workforce? A lot of things in there. As we come into second wave and possibly even third wave of COVID, we need to be able to make the right kind of supports in place, which speaks a lot to us about our policies. So, migrant labour in health systems, as anybody in this field knows, the high-income countries, particularly in Northern Europe, partly in Northern North America, and to a certain extent in Australasia and Oceania, are, if you like, highly dependent on foreign-trained health professionals here. And we can see some statistics here drawing on the OECD's numbers in around, I think it was 2015, and actually Ireland win the race here for being, we get top prize for being most reliant on foreign trained doctors. Now, in our time, of course, Ireland has exported lots of foreign trained doctors. It's part of our culture. We send out health professionals, we suck them in again, and people often rotate a lot. But what we can see here is very high dependency on foreign trained doctors, particularly in Ireland, and to a certain extent in some of the Nordic countries and in the UK. Why does this happen? Well, I think, it probably is done because you don't then have to train your own. It's significantly cheaper and it's quick. You don't have to hang around waiting for people to get trained. So the question is that exploitative? And probably in many cases it is, I would suggest. And so as a consequence of that, a few years ago, we had the WHO Global Code of Practice on the international recruitment of health personnel, and I expect my discussants will be talking about that freely as a way of saying, actually, some high-income countries, we have to step up here and we have to train what we need. Okay, so then, right, and I realise I'm rapidly running out of time, so I should just finish off on this key slide here, I think, really. So what does migrant labour do? Does it make our health systems more resilient or more vulnerable? And thanks for the Boris Johnson story. That was very good. At the moment, we have, according to a recent EuroHealth article, which was published last week, we have 9 EU countries who are seriously using migrant workforce to boost their surge capacity. So they're definitely filling the gap. But the question is, are they papering over the cracks to a certain extent? Are we not providing, are we not training enough of the healthcare resources, healthcare workforce that we need? Are we not? Is our care not structured properly? So we're needing too much of certain kind of health professionals that are in short supply. Big questions there. Questions about embeddedness of migrant workforce, given that the carousel, given maybe competition for people in the global setting. Is migrant labour liable to move on again? So actually, although you can import your way out of trouble, are you then vulnerable again to those people moving on? And then, of course, the key critical issue is that if you're importing migrant workers to help your health system, are you robbing another health system from their need and from their own resilience to a shock and a crisis? Around flexibility, clearly this can be, migrant workforce can bring knowledge, can bring learning. Chinese doctors in northern Italy, we saw very valuable, temporary migration bringing help where it's needed. On the other hand, if contracts are very rigid in terms of a migrant workforce, if they're only relating to a specific facility or a specific kind of work, does that mean that they can be easily redeployed, which you need to do to be resilient? And then finally, around motivation and engagement, which is so sorely needed right now. Will a migrant workforce actually get worse terms, and will it actually undermine the need to actually motivate all of our workforce sufficiently and well? So that there are risks there. And what we found in Ireland is some of our migrant doctors have been placed in positions which don't have training, which don't give promotion, which put them in a rural hospital, which both doesn't help engagement and it doesn't help flexibility. So one of the key, the tricky things here then, I think, is it comes down to a lot of the details. We can see that migrants may be important for helping us deal with our surge capacity, may be important for helping us with learning, but at the same time, there are risks there about if there's a lack of embeddedness, if there's contract rigidity, if there's an undermining of some of the other workforce and their need for proper support, then there's a problem. So there are key issues, I think, about how we deal with the policy, how we deal with the specifics around health worker migration, which mean we need to get into the details. So I'd just like to say thank you for that. I know I've overrun a bit. I spoke as fast as I could. And there are a couple of quick links there to the observatory report and also to the Centre for Health Policy website. Thank you.
Thank you very much, Steve. That was a very rich presentation and raising a number of very important points, and a number of points that I actually haven't seen before. such as, or rarely really, such as motivation, which are probably very important in practice. So thank you very much for that. We'll move over to the first remarks we have today from Jim Campbell. He is Executive Director of the Global Health Workforce Alliance, and he is Director of the Health Workforce Department at the World Health Organization. Jim, the floor is yours.
Friedrich, good afternoon to you, and thank you very much for the opportunity to speak at the launch of the MigResHub, and to Steve for that presentation. And thank you. I mean, I was asked to respond in particular, not to prepare remarks, so I will take on board that request. Clearly, we've seen a very big shift towards the whole discussion around resilience and resilient healthcare systems since the global financial crisis. And that has dominated. I think if you look at the bibliometrics, you know, we went from almost hardly any discussion to resilience to it being one of the most cited type of academic publications at one stage. And I think it's good that Steve is starting to unpack what does that mean in real terms, in program and policy terms, and even to be constantly reviewing that and looking again about how do we respond and manage to the shocks that healthcare systems are under. And indeed, at this moment in time, with the global pandemic of COVID-19, huge stress being placed on just about every country worldwide, and failings and challenges resulting from the lack of preparedness as a result of that. With this morning, we have just started the resumption of the 73rd World Health Assembly, and this debate is happening this morning in the remarks from our Director General in terms of an overview of the year, and also in the keynote plenary address from Her Royal Highness Princess Muna Al Hussein, who was talking to the International Year of Nurses and Midwives and some of the challenges that workforce has been facing throughout this year, and including in terms of their tireless efforts, but on many occasions, sadly, also resulting in the tragic loss of life as they put their responsibilities on the line. So clearly resilience is something that we're all concerned with. When you then come to looking at the pandemic, I think we need to be looking a bit beyond just the Steve's comments on the first and the second wave. Clearly there are going to be many multiple challenges, many multiple waves coming. That's the waves of infection, but also the waves beyond that, the ripple effects in terms of the impact on healthcare services. And we've got a complete disruption to all essential healthcare services around the world. Member state reporting demonstrating that often this is because of a lack of healthcare workers, or a lack of PPE, or a lack of any other capacity to deliver healthcare. And so there's a major backlog of health services, of clinical interventions, of operations, of procedures that have come and hit our healthcare systems in another major wave of work. There's going to be the wave that comes with the long-term stress, anxiety, burnout amongst our healthcare workforce. So when we start to look at resilience, we've got to build in not just the infections, but all these other elements for it. Looking then at the issue of our labor and the challenge around migrant labor. The Code of Practice is 10 years old. It's an agenda item for discussion at this week's World Health Assembly. Because it's a virtual meeting this year, because of the situation, we've had considerable discussion amongst all the permanent missions in Geneva and the representatives of the country through virtual technologies to actually go into detail and depth around the topic and the issues before the governing board is open. Clearly, The code is as relevant as ever. Migration is on the increase. And you've seen this through the surge that Steve was talking about. We have documented over 70 member states have introduced what we're calling a silent revolution in regulation to actually make that surge capacity easier. So it may be giving license to retirees, giving license to nurse students, giving license to medical students, any measure to try and build surge capacity through the regulatory frameworks. But in parallel, they're also making it easier for international labour mobility and migration. And the Boris Johnson comment, Friedrich, is very, very relevant. Not only did you hear Boris talking about it, but the UK has established a fund to support international recruitment of health personnel. And it's available in the sum of more than $30 million to attract health workers from abroad. So clearly, you know, we're seeing what has been described by some as a global scramble for healthcare workers, or a race to the bottom. And in response to this scramble, this race, we're seeing through regulatory mechanisms, some low middle income countries are putting regulatory in place to prevent migration. We've seen, you know, across in Asia, in Africa and elsewhere, that certificates of good standing will not be issued by a council or a regulatory body at this moment in time, deliberately to stem the flow of migration, because that surge capacity is needed in the host country. So clearly this is going to be a major issue. Migrant labour is at the heart of healthcare services around the world. It's not only the UK, it's not only in Ireland, it's not only in the European setting. Our data tells us that as many as one in four medical doctors are foreign born. And so they're practicing in a jurisdiction away from either their country of birth or their country of training. Similarly with pharmacists and dentists, as many as 1 in 3. We've published new data this year on nursing, 1 in 8 migrating into other countries. So this is a global phenomenon. And I'm really quite concerned that what we're seeing is an undersupply through years of poor financial decision-making with regard to the health and care, the right to health and care coming into impact. The austerity measures we saw in Ireland, Portugal, Greece, and elsewhere, you know, had detrimental impact on the ability to employ healthcare workers. And a few years later, a pandemic hits, and oh, crikey, problems. So I'm really very concerned that the years of underinvestment are really going to come home and make a major challenge, especially as Steve was talking about we're going to see wave after wave after wave testing the absorption capacity and resilience of healthcare systems in the next several years, including, you know, where the anticipation to vaccinate several billion of the population in 2021 with exactly the same capacity we have today, but more work being placed upon them. So really a very concerning moment in time, and migrant labour should be enabled, supported as part of ensuring that healthcare systems do, but at the same time, support and safeguards put in place so that we're not, you know, robbing Peter to pay Paul. Thank you very much.
Thank you very much, Jim, for these very wide-ranging remarks, reminding us of the challenges ahead, really. Let's move on to the second response and/or remarks. This is open by Isabella Aboderin. She holds the Perivoli Chair in Africa Research and Partnerships at the University of Bristol. Isabella, we are very interested what you can say to us today. The floor is yours.
Thank you very much. Thank you very much, Friedrich, and thank you very much for offering me the opportunity to participate in this discussion. And unlike Jim, I have actually prepared some remarks, and I have prepared them from the perspective of Africa as one of the key destination countries, and from the perspective of aging, because that is my discipline. I am a social gerontologist. And so what I'd like to focus on is one of the key challenges in health services, which is ensuring a continuum of care for those with ongoing losses in capacity and the integration of health services with more social services or long-term care services, in particular for care-dependent older adults or persons living with disability. I find that often debates about that integration between social and health services are often missing when we talk about health services and how to make them more resilient for the future. But I feel that our focus here on systems sort of opens up a space for thinking about this. And so what I'd like to do is to share some reflections on the idea and the opportunities of migration and systemic resilience in the provision of future integrated long-term care from a perspective of sub-Saharan Africa, as I mentioned before. And what I'd like to do is to distill a few thoughts, both on the conceptual frame for understanding systemic resilience, but also on emerging areas for research. And there are 3 points in particular that I thought I'd like to share, or 3 reflections. The first is that I think we need to consider systemic resilience in long-term care within the context of a broader, and I think it's fair to say, increasingly recognized need for a regime switch in the whole system of long-term care provision. Globally, I mean, we know that COVID has thrown into relief not only the precarity of sustaining care within current systems that across the world still rely in large part or almost exclusively on family-based and informal care provision, but COVID has also exposed the profound gaps in the quality and the adequacy of care provided and a lack in its integration with healthcare, as well as negative impacts of care work on the well-being and opportunities of mostly female unpaid or poorly paid caregivers, with impacts that have served to entrench gender and other social inequalities. So in both Europe and in Africa, therefore, there is a growing awareness that current systems of long-term care provision are not fit for purpose, and that there is a need for a fundamental shift in the configuration of the care diamond, away from family-based informal provisioning to expanded public provisioning and support infrastructures. So the question is perhaps no longer only how migrants have shaped the resilience of care systems under existing migration and employment policies, but how could and would they shape resilience in a very different future system? Rendered this way, I think it highlights a second point, which is the need, when we think about future of long-term care systems and their resilience, to consider explicitly broader development or macro imperatives that would have a bearing on both the need for care as well as the implications of migration. And here, when we think about Europe and sub-Saharan Africa, one imperative emerges in particular, which is the demographic imperative. In the EU, that is the rapid aging of populations coupled with increasing chronic disease, which will mean a rise in the need for quality long-term care provision at the same time as labor supply will fall as working age populations shrink. You could also argue that this implies for the EU an even greater need or an expanding need as we look into the future for migrant care provision. Not least because care work is also one of the sectors that is not expected to become increasingly or fully automated. In Africa, on the other hand, we also have a rapidly growing number of older adults, again coupled with rising chronic disease, which will also mean a rise in the need for quality integrated long-term care provision. However, only in absolute terms, because populations will remain the youngest globally, with a huge population, a bulge, if you like, of young working age people, and only a small percentage of older adults. Finding and expanding decent job and employment opportunities for this population of young people in Africa is viewed as critical for for the continent's progress and the nurturing of a demographic dividend. And the urgency of this has only been heightened by COVID, of course. So this implies for Africa a greater need for opportunities for migration and work, including in the care sector, which has actually been highlighted as one of the sectors for potential job creation and employment creation. So if you could imagine an expansion in care-related education and training in Africa to nurture a qualified care workforce that can supply the need within the region, as well as through formal labor migration in the EU or other destination countries, together with supporting migration or cooperation regimes, you could point, at least at this abstract and broad level, to the possibility of enhancing the resilience or performance of long-term care systems in both the EU and sub-Saharan Africa at once. And this, I think, highlights an important conceptual point, which is to consider the possible mutuality or interconnectedness of systemic resilience in care systems across two regions or countries. Now, all of this is quite high level and simplistic, if you like, but I do think it's important to consider exploring and investigating the potential connections through migration between long-term care systems in Europe and Africa, and the role that these could play in enhancing the resilience of both. And I can think of just 3 immediate areas for research that would be important in this regard. And some of these actually resonate with areas for research that you and Bridget highlighted in your paper. One would be an investigation of how attitudes are evolving towards migrant care workers from Africa across Europe or other destination countries, making sure, of course, to distinguish between those working in informal and those informal settings. Second, I think there is a space for macroeconomic modeling and policy simulations that could approximate some of the effects we could expect to see both in the EU and in Africa of expanded investments in public long-term care provisioning and support infrastructures, as well as care-related education and training. And as I mentioned, supportive migration regimes. And then lastly, I think it's important to think more carefully, perhaps, about what exactly resilience in long-term care provision would look like, would feel like. What are the critical elements of such care provision that would need to be sustained during or would need to be quickly recovered after a shock? For example, how important is the maintenance, the continuity of personal care relationships? I mean, these are big questions, but I think that considering care-focused theoretical perspectives, such as, for example, the ethics of care, could be really useful in that regard. I'll end with just 2 thoughts. The first is that I genuinely think this is a hugely exciting field or frontier for further research. And the second is that I see space and opportunities for such research endeavor, both as part of the broader international debate on the sort of the big reset in systems, economic, social systems that's needed in the face and the wake of the COVID crisis, as well as the more focused debate that's been ushered in by the Decade of Action on Healthy Aging, a WHO decade actually, on how to develop sustainable and equitable systems of long-term care provision that is integrated fully with healthcare provision globally. I'll stop here. Thanks very much. I hope I haven't taken too much time.
You certainly have not. Thank you very much for bringing in really insights that we otherwise would not have heard about. So this is very, it's great to have this in the session and to have these results from Africa in the picture, really. So I would like to start with a set of questions that have come up, I think that relate to all 3 of you. And that is about the relation between sending countries or origin countries and destination countries. So, well, one, say, perhaps broad question is, what are your personal favorites in terms of actually practically ensuring that the needs of sending countries are kept in mind, say? So a couple of policy options have been discussed, but perhaps you have a favorite, and you can tell us why. In fact, Paddy Siyanga Knudsen also wanted to know whether in Ireland there are particular origin countries of migrants working in Ireland. So that might be a hint of particular migration channels that have developed. And well, also to Isabella, is there any information that you have on how in practice origin countries try to avoid emigration? So on the one hand, they have to train professionals for their own needs, but on the other hand, once you have trained somebody, they could just as well leave, perhaps, or it's a lot easier. So what in practice has seemed to work to supply also the domestic market, really? Let's start in the order of the speakers, if that's okay with Steve, please.
Thanks very much, Friedrich, and thanks very much for my other panelists for their interesting and valuable inputs. Okay, the easy questions. The migration channels for Ireland would probably be for doctors. There's quite a lot of doctors that come from Sudan or have come from Sudan. There's quite a big network of Sudanese doctors that were here and have relocated. There were a lot of GPs who used to come on locum from South Africa, and that used to be a sort of a loop. They would come for 3 months of a year and then go back to South Africa, perhaps to earn some hard currency. That I think that's been shut down now because there are less. I think there are the Department of whatever they are, the Inland Revenue has caught up on them now, so it's not such an attractive option. But that was a temporary migration loop that happened. Obviously nurses from the Philippines, but you would expect that. There has been a move towards much more structured bilateral government to government sort of agreements. So I know with some countries in South Asia, with India, and I think with Pakistan, there's been a much more structured relationship around bringing in doctors for a couple of years and then them going back again. So it used to be a free for all, and I think everyone's wised up to the fact that that's not very helpful. And so then that comes back to the point of how do we do it well. So I think it is most helpful if it is government to government. If there is obviously an oversupply in effect in the donor country, then that's great. But I think also that you know, and actually Ireland has increased its capacity to train its own doctors too, so it has expanded that as well. So, but I think obviously structured, my personal feeling, structured government to government relations are probably the way to do it.
Jim, you have the floor.
Thank you very much. Steve mentioned there about the Sudanese working in Ireland. One member of my team was part of brokering that agreement. She's from Sudan herself, and a Trinity College graduate. Steve may know her. And when we were in Dublin for the 4th Global Forum in 2017 on the health workforce, there was of course, the updated agreement between Ireland and Sudan was signed. There's an example of a government-to-government agreement. The couple of things here, on Wednesday or Thursday, probably Thursday, the member states will debate and discuss the recommendations of an expert advisory group on the Global Code of Practice, 10 years this year that it's been there, 6 years of discussion, development, 10 years of implementation. The recommendations of the advisory group are exactly that. How do you address to make sure that there are mutual benefits in the relationship between source countries, destination countries, and the health and care workers themselves? And that's the critical element to be involved in that. And indeed, we're probably going to see a new generation of agreements coming forward. The advisory group recommending that there are support and safeguards in place, and that we explicitly put those safeguards in place accordingly to achieve that. Government to government agreements, new generation coming out. I expect some announcements in the European context from member states around new, updated, revised policies, which there will be a decision this week in the Assembly with new, therefore, direction. And automatically we'll see member states in the European context, which you're looking at, talk about how they're going to immediately implement that guidance into their own domestic policy. And that's positive. We're getting leadership from member states coming in. I think part of the challenge, though, clearly is this whole issue, if there's oversupply somewhere else, but there may still be a shortage because there's underemployment. And what do you do then in a local labor market? And I can think of many across Africa, across Asia, across Europe even, where there are no necessarily posts in a government establishment, where the International Monetary Fund has actually encouraged and advised government not to increase its public sector payroll for health and social care. And therefore the education sector is still producing graduates, but there are no positions. So there's oversupply for employment. And that's where we need labor market assessments to come into place. It's not good enough just to say that there's unemployment and oversupply. We actually need a fundamental understanding of the failure in the labor market to come forward, and therefore give guidance, give no objection for new mechanisms of government-to-government agreement coming forward. And I think if we can generate that in the future, that will be the way that we manage this global scramble that we're seeing. And at the other end, clearly, greater investment in education and employment has to come through, both for healthcare, but also for integrated health and social care. Back to you, Friedrich.
Thank you very much, Isabella.
Yeah, maybe just a couple of points, which is perhaps to highlight, number one, what I consider to be the very different situation as far as healthcare personnel are concerned, if we think about Africa, and social care or long-term care personnel. For the most part, with the exception of a few countries, there are no trained long-term care personnel or qualified long-term carers in sub-Saharan African countries, because these countries do not have a well-defined long-term care system or sector of organized care provision. For the most part, care remains provided within families in an informal kind of setting. So, but there is a growing debate within African countries, and I think stimulated by the COVID crisis, about the fact that these systems, these family-based informal systems of long-term care provision, are not fit for purpose, and that there is a need for investment in an expansion of public provisioning and public social infrastructures to support the provision of care, also to Africa's growing population of older people. And in conjunction with that, there is debate about the need to invest more in education and training and skills development, so you ensure that you have a qualified care workforce that can provide long-term care. So this is very much with a view to the future. But if you do that, if you invest in care personnel, a care workforce that can be absorbed both internally by an expanding formal long-term care provision service, but also can perhaps contribute migrant labor to supply labor where there are shortages elsewhere, this could end up benefiting the continent in both ways. So given the youth bulge that I spoke about.
Thank you very much. That's very interesting. Well, I think a second set of questions that I've seen follows on from that. So it starts with the observation again by Joel Buenaventura that basically health workers are lacking everywhere. So I would say there's kind of two options. One is to bring in more health workers, somehow find more of them. So that brings us back to the silent revolution, Jim, that you mentioned. In this context, there was a question from Bridget Anderson, whether there's also other forms of mobility that are helpful, perhaps, or that could have a significant effect in this context, such as redeployment. So not just standard migration as we know, but something like redeployment. And overall, I think the question is a bit in the room. These marginal, let's say marginal, not in a pejorative way, but they are brought in a crisis. These extra health workers that are that can practice then without the normal qualificational procedures. Is that enough in the sense that how big is the quantitative effect? And the other option, of course, that there is by and large is to sort of get more out of your existing stock of health workers. I'm thinking very crudely here, sort of a somewhat schematic economic approach. And then that begs the question, do we have to think about new forms of work that allow sort of these skills where they are available to be used more broadly and to be less, say, exclusive or less stuck to a particular context or particular location? For example, in Africa, if like a long-term care system is being built up, that is of course also an opportunity to start with a system that is perhaps more flexible and that uses these scarce resources more efficiently than many other existing systems. So is there any push towards something like ambulatory services, a way to keep care family-based, but bringing skills through like weekly visits, things like that? So I'm not an expert on this. I'm just raising this sort of quite open question. Steve, if you want to go first.
Thanks so much. What a privilege to respond to that. Okay, I mean, okay, first, as an economist, I hate that idea of squeezing more, so I'm going to walk against type for that. I think one of the key problems of trying to squeeze more is that actually in the middle of a pandemic, you make people more susceptible. You increase their exposure, frontline healthcare workers, and I think you know, results from China have shown that is exactly the last thing you want to do. Otherwise, you know, the infection rates go up with your healthcare workers. So I think longer hours for healthcare workers is not a good idea. I think there is, and this is not a new idea, but the idea of new cadres, new professional groups, giving standing to people with skills who haven't had it before, maybe a way of relieving some of the current crises, and what actually thinking quite carefully about, well, what skills do you actually need, rather than we need doctors or we need nurses, what skills do you actually need to deal with particular challenges, and therefore fashioning professional training and skills and accreditation, which maybe speaks to both to Jim and Isabella's points. I think that, and that may be a way of getting investment and legitimizing something which has been more informal. I think that there are the challenges with that too, obviously, the challenges of turf. There are challenges of you know, scarce resources. There are challenges of, you know, how do you get then a professional career ladder for that particular new group, and how you think about that. And also, the more you professionalize something, the easier it is to trade again. So you might be back to robbing Peter and paying Paul, but there may be something in that, and I'm sure Jim and Isabella can probably speak to that in a more learned way than me.
Thank you very much. Jim, if you want to intervene.
Yeah, I think we've looked at this in depth in the last 5-6 years, both in the global strategy on human resources for health linked to the Sustainable Development Goals and the ambition of the SDG 3, also in the high-level Commission on Health, Employment and Economic Growth, and looking at the much more from a labour human capital perspective and what we could learn from that to apply into integrated health and care services. I actually agree with Steve. Labour is, has an elasticity to a degree, but if you stretch it too far, we're into major challenges around quality, clinical care outcomes, infections amongst patient safety, but also health worker safety. And so it's just not advised to keep on squeezing. And actually, we must put in place the basic rights of health workers and care workers, occupational health and safety rights, labor rights, the right to associate, the right to negotiate, etc., has to be in place to protect this workforce. We can't do it. That said, we do need efficiency and greater efficiency gains to do that. And we're about to publish, we spent a couple of years looking at this challenge. We're about to publish the work of over 200 educational experts around the world for the last couple of years, looking at what competencies will we need to achieve universal health coverage in our teams. Not which occupations, not which job titles, but what competencies do we need in our teams to be able to deliver against the ambition. And actually, we saw some of this recently. Scotland has published a workforce strategy for integrated health and social care this year, and really does bring on board exactly that thinking. And then you can translate those competencies, the skills, the behavior, the knowledge, the attitudes, into what type of education, and therefore what type of registration and what occupational classification may that be. But it's teamwork. I would, we're for several years now, WHO in our health workforce department, we do not talk about task shifting because it's the multidisciplinary team that's still responsible for activities and tasks. So it's much more about roles and scope of practice within the team. You can't just shift the task. The team is still responsible for it. But the underlying economics of this, the underlying labor market, the underlying moral and ethical position on this is we're going to need to invest more, irrespective of the demands upon our health and social care means that the existing workforce is not going to be sufficient to respond to those populations, even with efficiency, even with technology, even with new models. We are still going to need to produce and employ more into the market for the future. And there may be ways of doing that. And Isabella was touching upon, some of the thinking around that. Maybe there is time now to be looking at greater labor mobility and migration to supply a, global, very well educated, licensed, accredited health and care workers that can be able to migrate through healthcare systems responding to global demand. Maybe we need to be rethinking that rather than every country fighting for themselves. Back to you.
Thank you. Isabella, the floor is yours.
Thank you, Friedrich. Maybe just a couple of points. I do think that as far as long-term care is concerned, there is an opportunity really in Africa to sort of fundamentally rethink or start from scratch in thinking about the kinds of skills and competencies that a long-term care workforce needs, how these can be deployed efficiently in systems that are appropriate and that perhaps avoid some of the mistakes or some of the shortcomings that we've seen in long-term care systems elsewhere. And this is because there is an opportunity now, as I mentioned, to build these systems, to start building these systems. So there is the opportunity. There is also, I think it's fair to say, a definite sort of political will or push to do so, as part of, I think, a growing emphasis on homegrown development solutions in the continent. So an explicit, not rejection as such, but awareness about Western models and the extent to which they are appropriate for the continent, the extent to which they have benefited the continent thus far. And in particular, I think that's quite interesting, in particular, as long-term care for older people is concerned, there is a sense that Africa needs to develop its own systems that build on strengths and values in its own cultural and social structures, to ensure that these systems and the care then that's provided is of good quality and is appropriate. So there is, in short, there is an opportunity to rethink what a care force might look like. And there is no reason why that rethinking that might go on in the African context cannot also inform and perhaps, cross-fertilize the thinking around the future of long-term care systems that is going on elsewhere in the world, in Europe or in other parts.
Thank you very much. I'll take a second to defend myself. I was not suggesting to squeeze the existing health workers more who are already doing so much and who you convincingly argued are close to burnout. I can imagine. I was thinking more in terms of new forms or new ways of work that could reduce the workload where it's possible to do so. Something like technology. I mean, I'm coming from a layman's perspective here. There has been lots of discussion about robots also in social care, and then there has been a discussion about giving medical advice basically over the internet, which could sort of keep a lot of people out of emergency services who just turn up because they are worried. But that's just in my defense. At least this gave you the opportunity to make a passionate case for the performance of the health workers, and that's all fine and well. Some more questions, actually quite concrete. One from Martin Roos. He asked to, and again, this refers pretty much to everyone equally, to talk a bit more about the interplay of domestic training systems, even where they are built up, and immigration policies. So to what extent, in your experience, are these two aligned in the first place? And then how can we ensure that domestic training and recruitment of domestic workers for the health system and for social care is not discouraged by having immigration policies for such workers at the same time? And a related question from Bridget Anderson was, so to what extent, do you think it will remain necessary to have a significant amount of, I would add here, low-skilled workers in these systems, in the sense that, like, there are just these kinds of jobs and they will have to be filled, in the sense that there's no alternative in the way of restructuring the health, the delivery of health services through technology, for example, that will make it less labor intensive. If it's okay, Steve, do you want to start again?
Yeah, there's a lot in there. I think one of the historic policies for Ireland in particular was to underfund medical training, to underfund doctor training, and so there was a cap on the number of places, which wasn't enough to meet needs. So the universities basically went out and said, okay, we're going to train foreign health professionals. And the consequent result of that was the universities managed to boost their income sufficiently well, but the embeddedness of such people, for one reason or the other, for push or pull factors, wasn't very strong, so people would then go. So there was the system, in essence, was going to work against you. You weren't going to be able to train enough health professionals because of the training, because of the lack of funding for training. That has shifted now, so that the government has expanded its capacity. I think the big problem we have, and this is perhaps coming back to what Jim mentioned earlier, is that there's been such a loss of morale in the health workforce. And there was actually a moratorium on hiring in the public sector for quite a while. And there's a general culture anyway of people moving, so that actually there's, even when there are posts and there should be demand, it isn't there because people don't want to work in the system because they see it as being under-resourced. And they see the lack and the problems thereof. So there's a culture of migration anyway in Ireland, but I think also there are key issues of the legacy of austerity and the legacy of previous attempted reforms, which hasn't worked very well, generally impacting on the workforce demotivation. And causing problems for retention. So I think there are lots of issues around retention of your workforce, not just migration in, but can we look after those and support those who we have. So I think that there is a complex dynamic in there. Yeah, sorry, that's my immediate front of the brain thoughts on that. Sorry, I've given the others a chance. The more I talk, the more chance they get to think. So they're going to make much more intelligent responses now.
Well, thank you very much. I mean, these are difficult questions, and they are not easily resolved, not by us today within an hour. So, Jim, please, what is your perspective?
Yeah, just a couple of thoughts on those two questions. The domestic training and the migration policy. One first, clear disconnect around the world. Again, the evidence that we've got, in partnership with a number of UN agencies and other stakeholders, we have an international platform on health worker mobility, looking at the interconnectedness across sectors on this. And far too often, migration is linked to agreements on goods, trade and services, economic areas, or agreements that are put in place to support certain activities coming forward. And whilst we may be on one moment recommending that we need to be extremely careful around the migration of health personnel without disrupting the healthcare system somewhere, we'll have another organization actually trying to promote the exchange of services between countries. And giving good argument to it. Migration policy is not being necessarily discussed and tabled by ministries of health. It's cabinet, it's finance, it's trade, it's labour that are making executive decisions here and causing some of the challenge. And then what happens is the Ministry of Health starts to put in place conditionality on the health workforce. We start to see the sudden introduction of compulsory service agreements. We start to see the restriction on certificates of good standing. We start to see, labour rights being eroded because other parts of government have enabled migration to happen. And you've got disconnection, education, health, governance, migration, labour, mobility. And so we need an intersectoral approach to it. On the second question from Bridget on the whole issue of skills, again, if we look at it from the competency and team perspective, there are members of that team that you can educate with maybe a one-year program of education and learning and certification can give you the necessary competencies to perform ably within the team. Now that's traditionally been the low skill discussion, but it's actually it's a really critical member of the multidisciplinary team that's going to be needed to do it. And it makes economic sense. It's an optimization model. It's a scope of practice model. If you look at the demands for primary healthcare, if you look at even what Isabella's talking about with a professionalization of care services for an active aging approach, you can deliver many of those competencies within 12 to 36 months of education with the right education and the right training. They are highly skilled in a particular function and thing, and health and care systems will need that group, and therefore we need to make the linkage between education, competencies, and employment in a much more robust way for the future. And open up, I do believe we need to literally consider opening up better, more supportive and safeguard measures for greater migration into health and social care in OECD countries, and give opportunity, economic opportunity, especially when you think 70% of our workforce around the world are women. We need to offer link to SDG 5 and gender opportunity, gender empowerment at the same time. Thank you.
Thank you, Isabella.
So I'm last, but Steve, I'm not sure I have anything intelligent, particularly intelligent to say. So perhaps maybe just two quick points. The first is perhaps it's a repeat of what I said before, but that I think there is an opportunity here. If we think about domestic training systems and immigration policies, at least as far as long-term care is concerned, I think there is an opportunity to develop international agreements or accords or some kind of a way of aligning training systems, say in Sub-Saharan Africa, with immigration policies and needs for care labor elsewhere, in a way that benefits the whole. Simply, as I said, because we're starting more or less from scratch. So I think there is an space here, an opportunity here for ensuring that the disconnect that Jim spoke about doesn't arise as far as long-term care is concerned or is minimized. The other question, Bridget's question about low-skilled, do we need low-skilled labor and migrants? The first point here, I think it's essentially the same as Jim said, which is it's a question of what we value. You know, we term them low-skilled, but the competencies they have are hugely valuable and perhaps indispensable as far as long-term care is concerned. In particular, if we think about, you know, the ethics of care, what care really needs to involve, the interpersonal aspect of care provision. So I think it's as much a question of the value we ascribe to the work that is done as it is the skills that people really have. And linked to that, I think you referred to technology, where technology perhaps isn't available to substitute for care provision by low-skilled care workers. Maybe that's not desirable. I mean, maybe the technology is there, but maybe that's not where we want care systems to go, at least as far as long-term care is concerned. I think that's it.
Yeah, that is a very good point. Perhaps there has to be a human face to it, and that makes perhaps a lot of the difference in actually the delivery of these services. We have, well, I'll mention one last question that has come up, but we don't have to do the full round of this. If you have an idea, Lucinda Allen mentioned the Brexit and effect that this will have for the provision of health services in the UK, because for the many often EU migrants, but also from New Zealand, okay, for those from New Zealand, not much or not too much might change, but for the EU migrants, it will get a lot more difficult and perhaps then also less attractive to work in the UK and to go there and sort of train in their systems in the first place. So I'm speculating here a bit, but we have seen already an effect on a high-skilled immigration to the UK and on the interest of highly qualified migrants to work in the UK, given just the uncertainty about Brexit and what their status would be. So if you were approached by the NHS, like we are thinking about how to react to this development that is coming, that perhaps we have a shortage of migrants in the NHS, what would be an element of your response to them? Just if you have, if there's anything coming to your mind spontaneously. Yeah, Jim, please go ahead.
Indeed, I mean, I think the numbers are quite frightening in terms of the projected shortages in the UK, you know, dealing with COVID, dealing with this resilience issue, dealing with Brexit. Projected shortage of 110,000 health workers, health and care workers in the immediate future, at the same time as some of the migration, the freedom of movement is disappearing. Number of publications have come out already this year on that exact topic, NHS employers, NHS Confederation, others also looking about how do they learn from the COVID response in terms of flexibility of the workforce in future, how do we get further forward? But the reality is that in a global market with a global shortage, they have to produce greater numbers to be self-sustainable. The evidence is available. The political leadership needs to actually implement the evidence. Greater investment in education and employment.
Thank you. Any more ideas that you want to mention at this point? Okay, then we have arrived at the end of this session. Thank you so much, Steve Thomas, Jim Campbell, and Isabella Aboderin for this really interesting session. I think it was very accessible also to non-experts and discussed some really difficult questions in a way that was thought-provoking. So thank you very much. And our conference will continue in 15 minutes at 2:30 Central European time with more on resilience of social care and the role of migrants in that. So thank you very much, and perhaps I'll see you later.